I'm Dr. Jennifer Robinson. I'm a professor at the University of Iowa in the Department of Public Health and the College of Medicine. And so I was the lead author on a National Lipid Association statement on enhancing the value of PCSK9 monoclonal antibodies by better selecting patients who will benefit most. And so the whole idea of this statement we thought was needed to really update the 2018 AHA-ACC cholesterol guideline, which had really focused on the low value given to PCSK9 inhibitors, even though they were shown to reduce cardiovascular events. And so what's happened since the guidelines is the price of these drugs has been dramatically reduced by 60%. And they have also, we have a whole bunch of subgroup analyses from the clinical trials that really show there are groups of patients that are very high risk and they had a huge benefit from these drugs. And so what we did for this statement, we did a systematic review of all of these subgroups. And what we started to see was sort of some patient phenotypes emerge where we could easily as clinicians think about who we should be targeting for PCSK9 monoclonal antibody therapy. And so the first group we identified were extremely high-risk people. These are people with 45% 10-year ASCVD risk equivalents. These are people with polyvascular disease, recurrent recent MIs within 2 years, a big burden, just a big burden of active atherosclerosis in the setting of a poorly controlled cardiometabolic milieu. And so I'm kind of drawing the picture, but these people are the obese patient, multiple risk factors, poorly controlled risk factors. And those people, it's cost effective, it's reasonable to treat at 100,000 per quality adjusted life year if their LDL is over 70. And it's actually a good value, less than 50,000 per quality adjusted life year once the LDL is over 100. So these are people, big benefit and very acceptable in terms of other patients that we are currently treating with these on-patent drugs. The next group are the very high-risk group. So again, thinking of our poorly controlled risk factor patient, but with less extensive disease. Maybe they just had a single blood vessel, either stroke, heart, a single heart attack. But again, that poorly controlled cardiometabolic milieu, diabetes, etc. And those, again, LDLs over 100 are where it's going to be a reasonable value. And once the LDL starts getting even higher, it can be a good value for even some of those people. And finally, there's another group, people who maybe just have a single cardiovascular event, well-controlled risk factors, or primary prevention, heterozygous FH, or severe hypercholesterolemia with LDLs of 220 or greater with risk factors. And for those people, an LDL over 130, again, it's a reasonable value to use PCSK9 inhibitors. So we really looked at the evidence and thought there were a lot more patients who we should be focusing on therapy, and this statement gives some guidance on who we should be targeting for PCSK9 monoclonal antibody therapy.